Since about 5 years now, Bhutan and Rwanda were the first countries the first low and middle income countries, I should say, were the first to implement HPV vaccination on a nationwide scale. This is because the governments were quite public health orientated, and so they rolled out these vaccination programs. But obviously the evidence for the impact of these vaccination programs, which are primarily on young girls prior to sexual activity, will not be seen on cancer for 20 years. These governments need a little bit of evidence that they are getting some sort of impact for their investment earlier. And so we are there basically to try to show the impact of the vaccination on the prevalence of the virus itself, HPV, in sexually active girls. First of all, I would say, before we even get into talking about the impact on the virus itself, what was very clear is the success in terms of the coverage of the target population that is associated with a school-based delivery approach. So targeting, working with schools, targeting children, young girls. The actual target age group was 12 years old, but they actually had an initial catch-up campaign up to 18 years old. But doing that with school was associated in Bhutan with an almost ubiquitous uptake of the vaccine in the target age group. Now, following this initial campaign, they switched the delivery approach to something that was more routine for vaccinations, which is doing it through basic health centres. And they noticed after a few years that the coverage of the target population of 12-year-olds was dropping. We were able to work with them to sort of produce this data and publish it, which will be a good model for other countries. But they themselves already realised that this was not good enough. And so, since 2014, they have switched their vaccination approach back to a school-based delivery. Even though it costs a little bit more and it is a little bit more arduous, then they clearly see the benefit. That's happened in Bhutan. Rwanda have kept a purely school-based approach, but they too noticed that when they tried to capture the girls that were outside school, that the success in getting the coverage of vaccination in those girls was also much lower. What I've been talking now about is really just the coverage of the vaccination, just how many girls were getting access, which was almost the first step. What's very important in Rwanda is that a large portion of the population are HIV positive, and that's something that we all saw also in our study. So basically, what we went on to do was to, in a sample of women, was actually to try and understand what was the prevalence of the virus in the young women in the populations before the vaccination program. And then we will be repeating this work in the following years to really show the impact of this high coverage, because they did get high coverage of it, on the actual virus itself. It does look like it's going well, and what the real sort of thing that we piloted for the first time, which has given us the first results, actually earlier than we'd expected, is to use urine sampling to get an idea of the prevalence of the virus in the young age population. Because, of course, you have to wait to see the impact of the vaccination in these young girls as they grow up. And young girls don't like to go for gynecological exams. I mean, it's true, you can understand, they don't need it. So the people that you tend to be able to study are an opportunistic, biased group. But urine testing was something that we found could be very feasible, acceptable to a wide range of pretty young girls between 17 and 19. And was able to get a representative sample. And then in that group, the question is, have we seen anything? Yes, we already see in that age group of girls an impact of the vaccinated girls have lower HPV prevalence against the cervical cancer causing types than the girls that did not have a chance to get vaccinated. Well, we haven't yet been able to address that. Evidence would suggest yes. Evidence would suggest that perhaps they have even more to gain because they are more at risk of developing cervical cancer. But this certainly, as the years go on and these girls grow up and we repeat our surveys in older groups of women, then this is certainly an aspect that we want to know more about. We've basically set the baseline for future comparisons. Well, the beauty of vaccination is there's not much to do after the girls have had their vaccine, and perhaps the evidence is that we don't need to worry because this group of girls will be protected. Perhaps these first two countries will serve as sort of sentinel settings where other countries, low and middle income countries, will be supported through subsidized programs over the next years for to get vaccines into their own countries, can maybe rely on this evidence to show that yes, these vaccines do work also in the kind of settings that they can associate themselves with, and not only in places like the UK and Australia, which produce very good data but are very little similar to their settings. If you're going to invest in an HPV vaccination program, then monitoring the program is not essential. You may want to rely on data being generated by other long-standing collaborations through scientists. But if you want to do it, then probably the most quickest way to get some evidence to support your investment in the short term is to perhaps do some testing in urine samples among young girls. But make sure you get your sort of comparison group of unvaccinated girls quite quickly.